So the next speaker is Dr. Andrew Matthew. Andrew is no stranger to the Walnut Foundation. He's helped us out on a number of our educational initiatives over the years. Dr. Andrew is a senior staff psychologist at Princess Margaret Cancer Center. He's a clinician investigator in the Department of Surgery, Division of Urology, a member of the Department of Supportive Care, and co-lead of the Genitus Urinary Survivorship Program. He's also an associate professor in the Faculty of Medicine, University of Toronto, in the Departments of Surgery and Psychiatry. For the past 20 years, Andrew has worked in clinical and health psychology. His current clinical research focus involves urologic cancers and includes prevention, treatment, decision-making, sexual rehabilitation, survivorship, and patient quality of care. Andrew, thank you and welcome.
All right, well, thank you very much, Anthony, for that very kind introduction. I first of all just want to say, wow, I'm really very impressed with today's conference and the number of participants and the international flavor. I should say this is certainly the first international conference where I'm actually wearing sweatpants, but I guess that's one benefit of the pandemic situation and doing this by a video conference. I also just want to say that I really am proud to speak here today for the Walnut Foundation in the November True North presentation of this conference. I've been lucky enough to be invited as a friend of the Walnut Foundation for years, and as Anthony said, I've really enjoyed my engagement with the Walnut Foundation over these many years. I also wanted to thank Dr. Thwaites. I thought that was an excellent start off to the conference today, so I really truly appreciated it. And so today my talk is entitled "Many Manly Men Avoid Their Prostate: A Story of Delay, Denial, and Dissex." I'm kind of known for goofy titles, so I apologize. But also, as mentioned, I am a psychologist. It is my second choice. I wanted to be a comedian. I just don't happen to be as funny as Jay. And so I've become a psychologist. And let me just. So I had the opportunity to look at the website and look at the Walnut Foundation and just to comment on the amount of work and the effort and the mission of the Walnut Foundation is super impressive. And as you can see, just even from Dr. Thwaites' presentation, the importance of the message. I bring that up though, because you can really see that the prostate cancer is kind of the perfect storm that can really challenge our men. It makes it, a perfect storm is kind of defined as, and I think many of you know, but it's like either a bunch of storms coming together all at once or a bunch of negative factors coming together all at once to make a rather calamitous storm. And really prostate cancer represents this perfect storm for not getting screened, for not knowing your numbers, for not participating in research and not getting the care you need because of the many aspects of how prostate cancer affects people. And so I want to take you through this perfect storm because if we recognize it and we have some understanding of it, we can unpack those storms so it does not have that effect. The first is simple, men and health. Gender is considered to be one of the most important sociocultural factors influencing health and health behavior. Health outcomes for men are significantly inferior to women, and we know that for instance, in the US, women live on average to 81.6 years. Men live on average to 76.9 years. You can see on the chart to the right there. And there's especially some disparity in our older age group. And also very importantly is the trends over the last 50 years don't demonstrate a narrowing of the longevity gap. So for basically 50 years, it's more like 100 years. The idea, if you take a look to the chart to the right, the life expectancy of males and females really has not narrowed, and that's kind of striking given our advances in healthcare. Also part of the Storm 1 in Men and Health is that men are more prevalent in 6 of the 10 most common causes of death, those being heart disease, cancer, accidents, diabetes, nephrological disease, and suicide. And you can see here, apropos to our talk today, that cancer plays a big role in those common causes of death. There are large and persistent differences in the health and survival between white populations and Black populations. You can see here on the right, for both men and women, you have life expectancy for whites, all races, and then you see the green line below for Black populations, and you can see there's a striking difference. And then specifically to men, you can see here that Black males in particular are on the low end of the life expectancy altogether. So it is true, in kind of a more global sense, there are systemic bias issues that are very likely to play a role in that. As a psychologist, I'm more kind of working directly with people, and we can see some of the obvious reasons for the potential of this life expectancy disparity or health disparity. Physical environment harm in the workplace, of course, may play a role. Propensity for risk behaviors may play a role, like alcohol abuse, smoking, and the like. But we've also really recognized, and the researchers recognized, that masculinity beliefs has a significant influence on health behavior, which can affect our overall health and life expectancy for both, and this masculinity beliefs and related health behavior for both acute and chronic illness outcomes are starting to become more and more recognized. So what do I mean by men, health, and masculinity? Masculinity is defined as a socio-cultural construct that can vary depending on several factors, including time and life stage and social class. It's and ethnic community. But what is also important is that it's refers to a set of norms that individuals have internalized, and this can be societal norms, absolutely, as well as from our own immediate families and the role that, for instance, our fathers might have played. The kind of key aspects of masculinity are independence, a sense that a sense of autonomy, a sense of self-reliance. I can take care of myself, a sense of stoicism. There's nothing wrong with me. Be tough and strong. A real one is that I'm focusing on helping others. I don't want to burden others with my problems or my health issues, and I'll manage it on my own. Sexual prowess is a big aspect of the masculinity beliefs, as well as being competitive. It's not to say that you're either masculine or you're not masculine. It's a kind of a characteristic of an individual, and like all characteristics, they run along a continuum. That continuum is less traditional masculine beliefs to more traditional masculine beliefs, that kind of hegemonic beliefs. That's where the independence and self-reliance and stoicism and sexual prowess are all firing highly. So the beginnings of the pressures of masculinity is this belief system of be a man and do not show weakness. The ideals, as I mentioned, are self-reliance and competitiveness. And so when we take a look at the masculinity, we see that men can approach it in a number of different ways, or sometimes forced to approach it in a certain way. To be complicit, meaning that the belief is that be a man is the belief system you want to maintain. You sustain that masculinity. I am a man, and you really target those beliefs that I've just talked about as something that's important to your character. You can subordinate it if men are struggling to maintain those masculinity beliefs, to hit those masculinity ideals. Then they feel themselves a sense of failed masculinity, and they feel that they may be weak or dependent, and hence this can influence how they behave both in the world amongst them, but also in the healthcare community. And then marginalized group. And this is extremely interesting to me, in the idea that oftentimes when we take a look at those masculinity ideals, they lead towards a sense of achievement of excellent employment or large careers or power or wealth. And because of systemic biases, Black men may not have the same opportunities that, for instance, in comparison to white men, and hence they have, it's much more challenging to meet certain masculinity beliefs, and this can be extremely challenging for these men when they're excluded from masculinity. And this will become something that's important as I get later on in the talk. And we do know that that these masculinity beliefs certainly have effect on the impact of health and healthcare behavior. So we take a look at those masculine beliefs and how they directly impact healthcare behavior. And because, of course, my talk does end in the sexual health realm, I want you to just remember and highlight the fact of the importance of sexual prowess within these characteristics of masculinity. So when we combine men, the gender difference and health, right, and these masculinity beliefs, we really see that men are about half as likely to seek health care compared to women. Men have significantly lower levels of awareness of health risks compared to women. In terms of healthcare utilization, women visit their practitioners about 1/3 more than men do in their lifetime, and this is even controlling for fertility and pregnancy and birth. As well, men are less likely to be compliant to prescribed medications. They're less likely to comply to care plans or screening recommendations. And here we can really see the influence of masculinity in a couple studies here, talking about men with strong masculinity beliefs are half as likely as men with moderate masculine beliefs to receive preventive care. And so in many ways, and it's not a blamed thing, but we are certainly our own worst enemy when it comes to our health and our healthcare behavior. The third storm, the first being men and health, the second being men, health, and masculinity. The third one is really prostate cancer itself. And I don't have to spend much time on this, as Dr. Thwaites had talked about this, but just for instance, in Canada, about 23,000 men will be diagnosed in 2020. This represents about 20% of all cancers. And unfortunately, about 4,200 men will die of prostate cancer, which represents on average about 11 Canadian men will die of prostate cancer every day. And as Dr. Thwaites referred to, Black men have almost double the risk of developing prostate cancer compared to non-Black men. And a survey that was done in Canada found that many Black respondents weren't aware that they could be at high risk of the disease. And that is why I've put these screenshots in, because it is the efforts of the foundation, like the Walnut Foundation, that plays such an important role in making sure that Black men in particular and their families have access to health information and education that they otherwise certainly haven't been afforded. And so I just want to thank that. And the men here, I've worked very closely with Dr. Isaac on the right, as well as Anthony and Ken, and I just want to appreciate their efforts. The fourth storm is not just prostate cancer, but also prostate cancer and its effect on sexual health. And what this slide represents is that we collect what's called serial quality of life data on men that attend the clinic at our hospital. And so they come in and they fill out either a questionnaire or on an iPad and they fill out what's called the EPIC, which is a quality of life questionnaire specific to prostate cancer. And this represents about 1,000 men, and we took a look at what quality of life domains were affected, and notice that this is the chart for within 1 year. If we look down at the bottom of the chart here, you see urinary incontinence and urinary obstructive, bowel, sexual, and vitality. Those are the domains. And then if you look, you can see that the red refers to people that are having severe side effect profile in that domain, yellow, moderate, and mild in the green. We've shown here that there's radiation and surgery. That's the RAD and the surge. And this is not a comparison to say which treatment is better. This is much more to take a look at the effects of treatment itself. And you can see that it makes some sense that in urinary incontinence, surgery has a more detrimental impact. But if we take a look at bowel, say radiation has more detrimental impact. But what I want you to note is look at those bar graphs or the chart in the sexual realm. Now, if we take a look at this for all men greater than 1 year out. Now, we didn't restrict it. So remember that these are all comers. So it's not where we took a look at certain men who had certain procedures and whether there was nerve sparing or not, or their ages. We didn't look at that. This is just all comers. And they could be 13 months out of treatment or 5 years out from treatment. But we can certainly tell from this that their sexual health realm has been affected and will be affected over the long term. And if I just toggle back and forth, you can see that within 1 year, there's some red and yellow in the other domains. And then when we look at over 1 year, those have dropped significantly. And what you do see there is probably more associated with age. However, you can see that the sexual health arm has remained to be quite problematic for patients. And this is bore out in the literature. There's been a meta-analysis, which is a collection of all these studies where they take out the raw data, they manipulate them in a statistical way to determine levels of erectile dysfunction 2 years past a radical prostatectomy. And really, if we take a look at it, myself and others have published on the fact that long-term erectile dysfunction after radical prostatectomy, and this there are some similarities with radiation, is in the range of 40 to 75%. There's a big range because a lot of the studies are difficult to combine, but it's probably closer to the 75% than the 40% range. And I'm not suggesting that I'm presenting this to scare people. This is where we're looking at the effects. We're getting better at the treatments, more targeted treatments so that it has less effect on erectile functioning. But also we've done a poor job of responding to erectile dysfunction in the healthcare community. And I'll talk about that, but we're working hard to change that. And just to get a feel for it, sexual health, this isn't just an aging process because, quote, prostate cancer is an illness of older men. Sexual activity can be lifelong. We take a look, age 57 to 64 is about 73% sexually active, 65 to 74 years of age, about 53% active, age 75 to 85, we've got a full quarter, 25%, 26% sexually active. Half of this oldest group reported a frequency of 2 to 3 times per month. And I have to tell you that as soon as I read this literature, I, of course, made this slide and I immediately showed it to my wife with a grin on my face, but it didn't work. So again, still with stage storm 4, storm 1 being the effective gender, men and health, 2, men, health and masculinity, 3, prostate cancer itself, 4, prostate cancer and sexual health. We saw the lack of function in those previous slides. That wouldn't be too concerning if it wasn't bothersome, but it's very bothersome, right? 60% of patients report distress related to sexual dysfunction as moderate to severe. when we take a look, because we're unbelievably adaptive creatures, even men or people with disability, relatively significant physical disability, they adapt quite well. And when we take a look at level of bother or distress, they're more likely to be in the mild to moderate range. This goes to show you that that the disability, quote, the erectile dysfunction or sexual dysfunction maintains its distress over time, and that's problematic. So it's a significant impact on the patient, significant impact on the partner, and that's something to be very aware of, and also a significant impact on the couple. And so whenever we're working in the realm of sexual health, remember that it's a couple's problem, right? No single patient put up their hand and said, I want prostate cancer. It's not, you don't have to take ownership of it. You don't have to feel guilt or blame about it. You didn't put up your hand. You wouldn't put up your hand to have prostate cancer and or its treatment. This is something, it's called, sometimes in the literature, it's called the couple's disease. And that's because it requires the couple to face it together to be successful. But all that said and done, the single greatest impact on patients' patients' health-related quality of life, I believe, is the sexual health impact. So in order to understand this further, yes, men have bother or distress about it, but what does that mean? And I did some research a number of years ago to kind of unpack that, and what is the relationship of that distress? You know, what is the nature of that distress? And I don't want to talk about all of the nature of that distress, but what I want to do is highlight again, here we see masculinity, okay, as one of the single greatest impacts. When patients were asked about the stress, they talked about it as an impact on their sense of masculinity. And they even thought about the inadequacy of pleasing their partner. And in some cases, they even got to a level of treatment and regret. And with proper health education, and what Dr. Thwaites was talking about, is that there's a very strong belief in the health community that that patients can be successfully treated without reaching anywhere close to this level of treatment and regret. The patient's reaction, unfortunately, to the physical impact in terms of sexual functioning can not only lead from physical retreat from the partner, meaning not engaging in sexual, not reaching out and engaging, but also cognitive emotional, that kind of shutdown. Men have a tendency to sometimes avoid or put their head in the sand. And so they will withdraw from the partner altogether. And when we were interviewing the partners, they said they were far less concerned about the actual physical impact, the erectile dysfunction itself, but more distressed about the fact that their partner was retreating. This there is a section on this is mainly heterosexual relationships. We've done some research that bores out in a very similar way for gay men as well. And then we have the partner taking some ownership of the challenge or the problem when they're left isolated and they feel like they're not performing well enough, or they're inadequate to please their partner or even to arouse their partner. And you can see that can become quite complex. And again, as I said, you can see masculinity as being one of the primary experiences of patient distress. This is also borne out in the literature. The multivariate analysis, a rather sophisticated statistical analysis predicting sexual bother and prostate cancer patients. So what they do is they put a whole bunch of reasons why garnered from the literature as to why we may predict or why we might think men are experiencing this sexual bother. And incredibly, loss of masculinity was the only significant independent predictor of that sexual bother. And as a reminder, this analysis included the severity of erectile dysfunction. So the idea of the degree to which the sexual dysfunction created bother was most influenced by that sense of loss of masculinity, not above and beyond the actual severity of the erectile dysfunction. So distress related to ED may have far less to do with sexual performance and more to do with the resulting changes in masculine self-esteem. And it's important that, often when we talk about erectile functioning, we talk about it in terms of just the erection itself, and then performance in the bedroom. But it's beyond the bedroom. There's significant pervasiveness of sex in men. Sexual imaging, not only that men, the imagings is that men think about sex, a lot, a number of times a day, in terms of fantasy life, daydreaming, and then of course there's sex dreams. And when our ability to perform sexual activity the way we would like to is affected, it affects all of these sexual imagings, all of these imaginings, rather, all these thoughts that we have about sex, because we now see ourselves as being less sexual, have less sexual prowess. And then the pervasiveness of the impact of ED on masculinity, and this is what I was talking about before. In interviewing men, they talked about the fact that it never goes out of your mind, right? And this goes to that pervasiveness of sex for men. It's so much a part of a male psyche. You take his manhood away from him, you change that male, you change him entirely. As well, there is an apparent magnification of this effect in Black men compared to Caucasian men. African Americans rooted manhood irrevocably with sexual prowess. Nothing is so important apart from that to an African man. And this is where I said, remember that systematic impact of marginalization, the idea of not having access to masculinity and those masculinity beliefs because of systemic bias. So not having as much opportunity for employment and career and power and wealth. This may leave the Black man to take a look at the qualities of masculinity beliefs that are available to them, that being sexual, certainly one could be sexual prowess. And hence there can be, for Black men, a much higher focus on sexual prowess in terms of the connection to their sense of masculinity. And hence, when that is obstructed, it causes greater bother. So that's why we call it the perfect storm, right? The idea that that men and the idea of storm 1, men and health, storm 2, men and health and masculinity, storm 3, prostate cancer and sexual health, and then prostate cancer, sexual health, and masculinity. So perhaps no other disease illustrates the social construction of masculine identity more vividly than prostate cancer, an illness whose common treatment effects leave a man with a diminished sense of agency over their body. So what do we do about it? Well, as I said to you, I don't think we've been that successful responding to that. Treatments of men focused on erectile dysfunction have been primarily ineffective. Many focus on just the penis and that functioning. The idea of giving a little blue pill to a patient and sending them home just doesn't work. And there are reasons for that. And we're understanding those reasons more and more. But it assumes that sexual satisfaction and pleasure is only based on penetrative sex, and not even providing the idea of non-penetrative sex as a bridging mechanism as a person recovers. It's called, instead of intercourse, we can talk about outer course, or we're talking about heterosexual couples. Superficial approach, neglecting the comprehensive nature of the problem, the influence of masculinity, the influence of ethnic, cultural, gender, and sexual orientation differences, and having sensitivity to that, the influence of stigma. And also, as I said before, yes, we can certainly look at sexual health and work with the men alone, but having partners involved, I think, is essential for ultimate success. And we know that these traditional treatment approaches aren't working. There's poor uptake of services. 60% of men are interested in sexual health information services. This is exactly the same number that we get when we're evaluating in our hospital, but only 15% ask for help. That's why in our hospital, we put sexual health as part of a usual care program in order to, it's more of an opt-out than opt-in to make sure we access those men that want care. Poor adherence to proerectile medications. When we give out proerectile medications, there's about a 50% dropout in 1 year, and there's reason for that. In many cases, the damage that was done during, for instance, surgery takes time to recover, and we're not expecting those medications to work as well in the first year. And also the idea of not taking into account masculinity. Men will say to me, I don't want to be dependent on a pill. And the startling response to this is only about 20 to 40% of men remain sexually active 1 to 5 years post-radical prostatectomy, despite access or attempted use of proerectile aids, in many cases 2 or more aids. And that is, a truly unfortunate number because, as I'll show you in a moment, we do have some very successful approaches directly for erectile functioning. But what this really has brought to us is the idea that we need a different approach. And right now, the zeitgeist or the real movement is a biopsychosocial approach to sexuality. And this is where, of course, we include the biologic measures, and this is where we do biomedical recommendations. But we also take a look at the internal kind of psychological effect, the interpersonal effect, how it's affecting the company, the couple. And then also social cultural influence and the racial ethnic experiences, and make sure that we incorporate that into our healthcare approach. It's not that we're throwing the baby out with the bathwater. As I said, we have proerectile agents and devices that are quite successful in this population if used properly and if well understood. The idea is, as I said, giving a pill and having the gentleman leave my office doesn't work because there's not enough education around it, number one, and then also support over time to help patients adapt and help couples adapt to the use of proerectile agents. A little comic relief. There's a Viagra switch. If the light stays on for more than 4 hours, call your electrician. So innovative models of care. I've presented actually the True North Share Clinic to the Walnut Foundation before, so I won't spend a long time on this, but later on this afternoon, we're going to talk about the True North program, which is part of Movember's, and what it is their survivorship program, looking at different areas in which we know that men need assistance and their partners and families. And in particular, we have the sexual health program. This is an online program, and its user interface is like you're actually attending a hospital clinic visit, except you don't have the wait time or the parking costs. But we do use a biopsychosocial approach. It's a structured schedule with initial visit and 5 follow visits in the first year, with the second year of maintenance support over time. Notice the timeline is that we're not looking at a quick fix at 3 months post-treatment. We're looking at following you for a period of 2 years in order to help you gain the optimal sexual recovery. We have a personal health coach, which helps humanize the technology. Coaches are trained specifically, and then we can track, allows patients to have tracking and feedback, and physicians to have tracking and feedback, and the involvement of the partner. This is the Share Clinic. It has 25 videos and has videos of patients and surgeons and radiation oncologists and medical oncologists. And can be used on the phone, on a computer, or on a iPad. We've had some international and national impact. It does seem to result in better outcomes, both from an erection perspective, but also emotional well-being, couples intimacy, continued and ongoing use of proerectile agents, medications, and devices. And we're looking at the potential of an international rollout into Australia and New Zealand. It's now a Canadian-based system for now, but I'll have something to mention about that in a moment. So integrated care approaches, build it and they will come, establish processes of engaging men, the challenged by the perfect storm of prostate cancer and equals vulnerability. We need to overcome that. Sex is very important to men. So we can actually potentially use it as a potential motivator to get them into the healthcare system and then look at their broader overall health as well. But examples of innovations are the Walnut Foundation or the Movember Destigmatizing Campaign, because this is opening up the door. And as part of that, and it's is that the Movember Foundation, the Global Movember Foundation, has asked me to add this slide. They're developing a True North open access sexual health support product, which is like a sexual health information website for men and their partners who have faced prostate cancer. The goal is to design a virtual supportive care product. The process of development necessitates listening and learning, engaging with men with prostate cancer and their partners, including the being responsive to diverse populations, and in particular for today's talk, the unique needs of Black men and their families. So Movember is asking for your help. They need your feedback on this True North open access product, and I think it's a great opportunity because too often these types of products are very kind of Caucasian centric. And so I think getting input from members of the Walnut Foundation would be great. If you're interested, please email contact@truenorth.org or get in touch with the Walnut Foundation, and we can put you in the right direction. So there we go. And just to remember, there can be many reasons for erectile dysfunction. These are my sons, Will and Nick. They're twins. This was back in 2006, and you can imagine the impact that had on my sex life. Where there is love, there is life. I just want to say thank you very much for the opportunity to present today.
Thank you, Dr. Matthew, for this engaging presentation. First question says, do you see much depression or anxiety in men on active surveillance, or is that overstated? Is it difficult for men to learn to live with cancer?
I got you. So that's a very engaging question, and I want to answer in a way that hopefully is quite useful. So first of all, as you know, I'm a psychologist, so I examine characteristics of individuals, characterological qualities of individuals, and one of the things that's very apparent is that we all have different risk tolerances, and you'll notice that in terms of what's going on with the COVID situation, is that some people find that the threat of the COVID pandemic is so high, their risk tolerance is so low. You know, you'll find that they're closed in their basement. Other people can be quite dismissive of the risk and find themselves, getting in social gatherings and the like. So there's a variance in risk tolerance. And that's similarly true for a variance in risk tolerance in carrying the disease during active surveillance. It is also true that there may be some overstatement to the idea of anxiety and depression. When we take a look at it in the literature, it does play a role, but only about 20% of the population that are under active surveillance will say that the reason for transitioning to actual treatment is things like anxiety and depression. The single most influential aspect of what accounts for the transition from active surveillance to actual treatment is their relationship with their urologist or uro-oncologist or radiation oncologist and their trusted physician's recommendation.
Okay, thank you.
I have another question. What are the factors that contributes to the swelling or an enlarged prostate?
I think as Dr. Thwaite had mentioned, there are a number of reasons, for instance, why you might have a high PSA, and some of them can be prostatitis or BPH, and even recent sexual activity can cause agitation of the prostate, which will produce greater PSA. There's even some evidence of riding a bicycle. There's a small trial that says, if you ride a bicycle, you can agitate the prostate and cause some swelling. But as I'm a psychologist and not a physician, I'm going to step back from that question a little bit and recognize that we do have Dr. Pfeiffer coming on later this afternoon, and he will certainly be able to be more specific in an answer.
Okay. Next question is, do you have any data on QOFL for men on active surveillance versus those who have been treated for radiation or radical prostatectomy?
So quality of life, right? Active surveillance, radiation, and surgery, I think, is the question. And yes, it is true that the literature is strongly in the surgical area, so that we know a lot about the quality of life of patients after surgery. It just appears that urologists were doing more research for 10, 20 years ago and forward. Radiation oncologists are now doing much more research as well, so I think we have some good information on quality of life domains in that area. There is some complexity to that. And the idea is that if we take a look at, the things is these treatments change over time. And so their effect on quality of life changes over time. So in surgery, probably the major change has been the introduction of robotic radical prostatectomy. And there is some evidence that's coming out that it certainly helps in immediate recovery. So getting out of the hospital, there's less invasive. It's less invasive. The degree to which it does performs better in the different quality of life domains is still controversial, although there's some trend potentially for it having better outcomes in terms of erectile dysfunction. In radiation, there's been really significant changes over the last 20 years. When I started, they had basic external beam radiation, then they went to 3D conformal radiation, and then intensity modulated radiation, and now they have volumetric radiation. And what that means is that the radiation oncologists are getting better and better and better and better at targeting their radiation so that it has a less impact on healthy tissue and hence less side effect. And so in many ways, the treatments are very similar in terms of survival and in terms of their quality of life domains. In relation to active surveillance, obviously the domains that are affected from a physiological perspective, they show far less dysfunction in those domains just because they haven't been actively treated. And as Dr. Thrait's said, that the prostate cancer doesn't actually result in symptoms until late stage. That said, as well, it can be challenging from a psychological perspective to be in active surveillance. And it really goes to, as I said, your risk tolerance and the ability to not have it on your mind every day.
And just one quick follow-up question. Folks on the line might want to know how they get referred to your clinic.
That's a good question. And so I work out of Toronto, out of Princess Margaret Hospital, and we have a face-to-face clinic there. But we also have developed with Movember this True North Share Clinic. It was designed for Canada. There are other countries that were involved, but the idea is that the Share Clinic was designed for Canada, but it is now considered to be something that they might want to take more broadly. And so I'm sorry to say that I don't think there's access right away, but I think it might be coming as we start to spread it out. That said, if you remember at the very end of the talk, we talked about Movember.com, asking for your support. The international team, there was a national team in Canada that developed the Share Clinic. I was part of an international team to develop sexual health programming in the other countries that were involved. There was a US program as well. But we all got together to help Movember do this public access point. And they've put together this sexual health program that they would love your input in. And it's excellent. So don't necessarily wait for Share Clinic. Think about going to Movember.com and accessing that public product, which they will launch very soon after getting feedback.
Awesome. Thank you.
Thank you very much, Dr. and Matthew.